Senator Nirenberg, Senator Lewis,
Here.
Senator Hudson.
Thank you. Do we have a quorum? All right. With quorum being established, I make a motion that we go into executive session. Can I get a second? Thank you. I make a motion that we bring Senate Bill 336 before the body. This is Senator Moon's bill related to hospital price transparency. Can I get a second? Second. Thank you. Senate Bill 336 is before the body. There is a Senate committee substitute ending in .02C. Is there any discussion on that bill? Seeing no discussion, I move that we adopt Senate committee substitute for Senate Bill 336. Can I get a second? Second. All in favor, say aye. Thank you. I move to do pass Senate committee substitute for Senate Bill 336. Can I get a second? Second. All right, Secretary, please call the roll.
Senator Carter,
Aye.
Senator Lewis,
No.
Senator Nirenberg, Senator Hudson, Senator Bratton, Senator Nicola.
Aye.
So just for the record, we did have votes left with the committee prior because senators had. Can we do that?
Cannot change the outcomes. This is
Okay.
a 2-2.
All right. Thanks. All right. So that has not passed the committee because those votes cannot change the outcome.
That's right.
All right. All right. Thank you. All right. All right. I make a motion that we go to out of executive session. Can I get a second? Thank you. We are now out of executive session. So I make a motion that we go into presentations, and that is, we're going to start with Senator Rusty Black's bill. Senator, is he here? All right.
Good morning, Madam Chairman, members of the committee. For the record, my name is Rusty Black, and I represent the 12th Senate District in the great northwest part of the state of Missouri. Thank you for the opportunity to present Senate Bill 356, known as the Designated Healthcare Decision Maker Act. This legislation aims to establish a clear framework for making healthcare decisions on behalf of incapacitated patients who do not have an appointed guardian or durable power of attorney for health care. Under existing Missouri law, there are gaps in the process for determining who may make critical medical decisions for incapacitated individuals. Senate Bill 356 seeks to fill these gaps by creating a prioritized list of individuals who may act as a designated healthcare decision maker, ensuring that patients receive timely and appropriate medical care while safeguarding their rights and best interests. Key provisions of the bill include a structured process for determining incapacity and identifying an appropriate decision maker, legal protections for healthcare providers acting in good faith, safeguards against the discriminatory denial of medical care, provisions for addressing disagreements through the probate court system. By enacting this legislation, Missouri will provide much-needed clarity for families, healthcare providers, and facilities while ensuring that patients without legal representatives still receive proper medical attention. Due to the sensitive nature of this legislation, please understand that this bill is a work in progress, and I'm happy to work with the committee and others to address any issues. I want to, before I close, say that this bill has been something that's been discussed at our family events at home in King City for quite some period of time. I have several family members that are healthcare workers, from nurses to people that are doctors within the family. And they talk about these people getting trapped in places that there's probably more appropriate medical care for that individual because they don't have a family that I grew up in to help them make quality decisions for their life. And they get stuck in the system because they don't have somebody to take care of them. And this is something that my baby sister's pushing on me as much as anybody, that we've got to quit trapping these people in inappropriate care because they don't have that decision making. And there's not a large number of people, but our people are hurt because we don't have this in our state law. So with that, I thank you, and I'd be happy to try to answer any questions.
All right, thank you, Senator. Are there any questions for the senator? Senator Nicola?
Senator, thank you for bringing this legislation. I've had some personal experience with this too, and I know you said it's a work in progress, so I'd like to talk to you. I have questions about a couple things. I won't take any committee time. We can talk about those things, but I just want to thank you for bringing this to the committee.
Thank you. I know sometimes some of those things, and you, if you've worked with this, and I'm certain in your other capacity you've had to deal with this, we got to make sure that people are comfortable with what we end up with at the end. But it's something we put off for a long time because we're afraid to have some of those conversations. And people are getting hurt from the other side as people are scared of what might be some boogeyman down a hole. Okay? Thank you, Senator Nicola.
All right. Any other questions? Senator Lewis?
Good morning, Senator.
Good morning.
It's been a minute since we've chatted.
Yeah, unfortunately, my wife was listening last night part of the time. Fortunately, it wasn't while I was talking.
Well, I appreciate the spirit of the bill for sure. I've been in situations taking care of patients who were end of life and had no family with them, and me being the person to hold their hand as they take their last breath. So I get the spirit of the bill. I would like to work with you on some of the definitions, and I think that on page 6, 8 and 9, non-relative who can demonstrate they have a close personal relationship. A little bit of concern of like how do they demonstrate that? Are we going to have our healthcare professionals like interrogate people? So just want to work through maybe some of that, and then any other person, an 8 who's involved in the patient's care. Just want to make sure, and I think we want it to be family and people who care. So I think that just want to put on the record that I'd like to work with you on cleaning up this language.
Thank you very much, Senator. Let's
Thanks.
try to see if we can get this completed sometime in our lifetime here. And my guess is my death is coming soon, so we probably ought to try to do it this year.
Wow. Senator of the home of sliced bread, don't say that.
I'm not real good about taking my medication and listen to medical professionals. I had to grow up with them.
All right, any other questions for the senator? Seeing none, thank you, Senator. Any of those, who's here in favor of the legislation? All right, any opposed? All right, we'll go with those in favor first.
Chair, members of the committee, my name is Brent Hemphill. I'm here on behalf of the Mosaic Life Care. We're the health system in Northwest Missouri, where his sister works. Thank you for taking the time to have a hearing on this bill. I know it's a challenge to have these discussions. I dealt with them with my parents, but they did have a durable power of attorney. But when those folks don't have a durable power of attorney, it just puts them in that purgatory. And we literally have folks who have been parked in our hospital for months, and it's just not fair to those individuals to either receive the appropriate level of care or to move them into an environment that gives them the best quality of life. And so, Senator Lewis, to your comment, I think there's nothing in here that anybody is, this is a work of art that we need to bring all the parties together and try to come up with some resolution so we can fix this. So I want to have an opportunity to, again, thank the sponsor for doing this. This is a very delicate issue to talk about, but we've got to come up with a solution. It's my understanding, due to research, there's only about 4 states, including Missouri, that doesn't have this process to come up with a healthcare decision maker process when there is none currently and a person can't make a decision for themselves. So we would like to see this move forward.
All right, thank you for your testimony. Any questions, Senator Lewis?
I was kind of multitasking. We're one of how many states that don't have something?
My understanding, the only 4 states that don't have this are Massachusetts, Nebraska, New Jersey, and Missouri.
Okay. Yeah, and let's talk about like what other states are doing in the language and
Yeah.
stuff. So thank you.
Thank you.
All right, any other questions for the witness? Seeing none, thank you for your testimony. Make sure you leave a witness form. We're going to pause just for a minute and go back into executive session. I make the motion that we go into executive session. We'll come right back to hearing this bill, since senators have other bills that they have to be in other committees for. So I make the motion that we go into executive session. Can I get a second? Thank you. We're going to bring forward Senate Bill 149 before the body. This is related to food labeling. Can I get a second? Second. All right, Senate Bill 149 is before the body. There is a Senate committee substitute ending in .5C. Is there any discussion? Seeing none, I move to adopt Senate committee substitute for Senate Bill 149. Can I get a second? All in favor? I moved to do pass Senate committee substitute for Senate Bill 149. Can I get a second? Thank you. Secretary, call the roll. Yes.
Senator Hudson. Aye. Senator Nicola. Aye. Senator Nurnberg. Aye. Senator Lewis. Senator Carter.
Aye.
Senator Bratton. Aye. Gotcha. There we are.
Okay, with your vote of 6-0, the Senate bill is due pass. I now make a motion that we bring Senate Bill. Okay, thank you. That was a vote of 5-0. Thank you. All right. The motion do passes, the bill do passes. So now I make a motion to bring Senate Bill 519 before the body. This is related to the amount of prescriptions dispensed by pharmacies during emergency periods. Can I get a second? Senate Bill 519 is before the body. Is there any discussion? All right, I make a motion to move to do pass Senate Bill 519. Can I get a second? Secretary, call the roll.
Senator Hudson. Aye. Senator Bratton. Aye. Senator Nicola. Aye. Senator Nurnberg. Aye. Senator Lewis. Aye. Senator Carter.
Aye. All right, with your vote of 6-0, Senate Bill 519 is due pass. Now I make a motion to bring up Senate Bill 178 before the body. This is Senator Lewis's bill related to health care. Can I get a second? Second. Senate Bill 178, it was before the body. There is a Senate committee substitute ending in .02C. Is there any discussion on this? Senator Lewis, any discussion?
Yeah, I just want to thank Senator Nicola. He voiced some concerns during the hearing, and this was a couple weeks ago. We worked through all of those, and they are addressed in this. And one of it was just to ensure that mothers and babies, the mom can give consent for treatment, like such as syphilis or something. So we have that in there. And Senator Nicola, I believe we've addressed all your concerns.
Yeah, we do, and I appreciate it. Thank you.
All right, thank you. All right, so I make a motion to adopt Senate committee substitute for Senate Bill 178. Can I get a second? Second. All in favor?
Aye.
I move to do pass Senate committee substitute for Senate Bill 178. Can I get a second? Second. Secretary, call the roll.
Senator Hudson. Aye. Senator Bratton.
Aye.
Senator Nicola.
Aye.
Senator Nurnberg.
Aye.
Senator Lewis.
Aye.
Senator Carter.
Aye.
6-0.
All right, with your vote of 6-0, the Senate Bill 178 is due pass. I now make a motion that we go out of executive session. Can I get a second?
Second.
Thank you. We're out of executive session, and we'll pick up with testimony in favor of Senator Black's bill. Thank you, senators, I know you're busy, so.
Thank you, Madam Chair, members of the committee. Samuel Lee with Campaign Life Missouri to go on record in support of Senate Bill 356. I'm not going to belabor the point about what the bill does. I would just say that from the pro-life movement's perspective, this is consistent with legislation that has passed previously, going back to 1985, the Living Will Law, and then 1991, the Durable Power of Attorney for Health Care. Some years ago, and some revisions recently, the outside the hospital do not resuscitate order. This bill, like those bills, those laws, provide that proper balance between protection of the rights of the patient, safeguards for the patient, and the ability for healthcare providers to properly care for patients. In this case, those who are incapacitated and never designated someone to make healthcare decisions for them, or never signed a document doing that. It has safeguards, and we support it, and happy to answer any questions.
Thank you. Any questions for the witness? Seeing none, thank you for your testimony. Appreciate it. Next in favor?
Madam Chairwoman, members of the committee, my name is Bill Bates. I'm CEO of Leading Age Missouri. Leading Age is a not-for-profit association, a membership organization for almost exclusively not-for-profit aging service provider members. And that means our members provide nursing homes, assisted living, hospice, home care, home and community-based services. We also, our members are providing market rate and affordable housing care communities for those 55 and older. And when our members combine all of those levels of services, or some of them, into one campus or community, we call that a life plan community or a continuing care retirement community. Senator, thank you for bringing this bill forward. We are here in support of a bill moving forward. Senate Bill 356 addresses the unfortunately too common and difficult situation where, as described by other witnesses, a patient is incapacitated and needs a medical decision to be made and doesn't have a legal document that will inform that important decision. The language of Senate Bill 356 includes our member organizations definitionally as a healthcare provider or a healthcare facility, so I believed it was important that we come before you today and indicate we are in favor of legislation moving forward. And we have long supported such legislation for the difficult situation described. We support a consensus bill that is reasonable and balanced in dealing with this difficult situation, and our review of Senate Bill 356 meets that test for Leading Age Missouri. Candidly, and for full disclosure to the committee and understanding what you're working on, it's going to be a very unusual situation where this bill or the law or legislation would be triggered in a senior living community. However, in the situation, albeit infrequent, when it is triggered, it's going to be vitally important that the protections and the requirements and provisions of the law be in place to assist the patient, resident, healthcare provider, and healthcare facility. And to confirm what you've already heard, as you may know, Missouri is one of 4 states without a default surrogate consent law. Folks, or members of the committee, in a perfect world, everybody would have an advance directive that conveys the healthcare wishes of a person in need or designate somebody to make those decisions. But you know it's not a perfect world, and only about 1/3 of U.S. citizens have an advance directive to deal with this tough situation. So Missouri needs a fail-safe statute to provide guidance in these difficult situations. Our association has routinely supported bills that make Missouri health care better for the citizens of our state. And even though this legislation will be infrequently triggered in our communities, we think this improves health care in Missouri and would urge you to advance a bill to do that. Thank you. Are there any questions?
Thank you. Any questions for the witness? Seeing none, we appreciate your testimony. Make sure you fill out a witness form and leave it on the table there. Next, in favor? All right, seeing none. Any opposed? Seeing none. Thank you, Senator. Oh. Are we good? Okay. Still seeing none. Senator, you may close.
Thank you, Senator, for you and the committee taking time to hear the bill.
All right, thank you. All right, that concludes our the presentation on Senate Bill 356. Senator Shelton here? Okay. All right. All right. We're going to now hear the presentation on Senate Bill 520. I'm going to turn the gavel over to our vice chair.
Senator Carter, whenever you're ready.
Thank you. Mr. Chair, members of the committee, I'm Senator Jill Carter from the 32nd District, and I'm here to talk about Senate Bill 520. This bill is straightforward. It says every hospital emergency room in Missouri has to have a doctor on duty whenever it's open. It's about making sure people get the best care possible in emergencies. I was actually a little shocked to learn that we don't have doctors in emergency rooms. I would imagine that anyone who's having an emergency situation would like to know that there is a doctor on hand when they go to the emergency room. So this is a piece of legislation that was born out of that concern. Some worry this could hurt critical access hospitals, but that's not the goal. Indiana and Virginia have passed similar laws, and they've got more critical access hospitals than we do. 51 in Indiana compared to our 36. And they make it work without closing anything down. We can too. Emergency rooms are different. They're fast, unpredictable, and deal with life or death moments. Studies like this one from Stanford in 2022 show care is better and cheaper when the doctor leads the team, not just the nurse practitioners. I'm all for teamwork and have supported the scope of practice expansion for nurse practitioners. But a doctor needs to be there to take charge. I've lived in Southwest Missouri for over 36 years, so I get the struggles rural areas face with healthcare. This bill isn't about making things harder. It's about giving every Missourian, rural or urban, the same shot at top-notch emergency care. I'm happy to answer your questions and work with you on this.
Thank you, Senator, for bringing this forward. Appreciate it very much. Is there any questions for us? Go ahead.
Hi, Senator.
Hi.
It's always nice to see a simple bill, if you will, in terms of short and length, but just some questions for you. You know, I had a conversation yesterday about this, and it just kind of got me thinking, and then even in your comments as you opened, right, I in the vast majority, certainly the hospitals in my district, right, all have many physicians on staff at all times. I have North Kansas City Hospital, incredible hospital, right, because we have the capacity. It's a massive hospital. We are able to do and treat, level 1 traumas, all of these things. However, I recognize that different parts of the state look very different from my district. And I've been concerned over the years, way before my time in the legislature, at the rural hospital closings, at recognizing, for example, my family is up in Livingston County, the home of sliced bread, and we have, for example, when my, grandma had a stroke, I was so thankful that rural hospital was still there in Chillicothe, that they were able to stabilize her, then to get her to Kansas City and get the additional care, right? So I recognize how important and how vital our rural hospitals are. However, I also recognize that when, a family member of mine has had a heart attack or a stroke, that the person that's responding in our home or in a restaurant or in a parking lot isn't a physician. They're a trained paramedic who knows how, they have the training to get somebody stabilized, right? And those life-saving measures, all of that, right? That's why I say
Compounds,
get
right.
everybody get trained
Yeah.
in CPR and know how to use a defibrillator, all of these things, right? Because it's life-saving care, and I can administer that care. I'm not trained at any way other than CPR, but I can administer quick life-saving care because I had limited training, but at least to get somebody stabilized, so then to get them to the next place, right? So that's just kind of one of the things that I recognize, well, actually, I don't want to do anything that would actually further hinder these hospitals to be able to stay open and have somebody there who has had a lot of training to be able to get them. And then, obviously, most of they have a physician that's on call. I grew up with my mom she was a physician, running to the hospital to deliver the baby once the baby was, all of those things I recognize, right? But sometimes just getting that piece in there, it's so important that we have these hospitals that as people are truly having life-saving emergencies, right? Not the stitches or the broken bones that can wait a
Right.
little bit.
Life
The
or death.
life or death situations. So anyway, I just was thinking about that, and like I said, I would trust anybody, a paramedic that's rushing in to my home to administer CPR to my kid or whatever, right? And they're not a physician, but I trust them in that moment to provide that life-saving care.
No, I share your concerns. This is something that I think is a good discussion to be having. Like I said, other states like Indiana and Virginia have passed similar legislation where they have more critical access hospitals than we do. And this legislation has passed there, and it hasn't closed the hospitals down. Another thing to consider is having a doctor on hand. I would say that now I'm asking the questions, and I've talked to several of our hospital CEOs about this piece of legislation actually, and just wanting to know how it would impact them, their thoughts and perspectives on that. Knowing now that my rural hospital that's 10 minutes away doesn't have a doctor, I don't know that I'm going to go to that hospital. Does that make sense? Like, I'm going to make sure that the ambulance
But
or whoever.
You can't say if somebody's having a heart attack or a stroke or whatever,
No, well,
having
if-
a long seizure that's prolonged or whatever it may be, like you're going to try to get them somewhere to get.
Exactly, to stabilize them. Like, I get that. But if I think if it's a life or death situation, I'm going to try my best to encourage the ambulance to go to a hospital that has a doctor or someone else. I'm just saying, I don't know that the vast majority of people know that there's not a doctor on hand when they're taking you to the hospital. And the other thing is, when you have a doctor who is at least on call, or usually there is a doctor that's on call, so if there's a situation, they can go into the emergency room. But studies have shown, and I'm happy to share these studies with you, that having a doctor on hand actually saves costs for those critical care hospitals, because getting that treatment earlier often reduces the costs later. So there
No,
are
and
people.
I appreciate.
Yeah.
And like I said, I appreciate the conversation, and like those were just some initial thoughts, right? I also appreciate what the legislature has done in recent years to really incentivize rural medicine and making sure that we have more
Exactly.
folks going into rural medicine. I mean, I can't speak highly enough of the med program now in St. Joe to get rural doctors trained. We obviously want access in all parts of our state. But I just want to make sure that we're not going to do anything that actually hurts these hospitals that are hanging on sometimes by their fingernails.
Well, and Senator, that obviously that is a deep concern that I have and share with you as well. So, like most legislation and most conversations, these are really critical conversations that we're having. I'm grateful that we have testimony here,
Sure.
to shed more light on this. And this is just a good discussion again that we'll continue to have, but one that I think is important to have.
Yep. Thank you so
I
much.
honestly was shocked, and I think a vast majority of Missourians would be shocked to know that there's not doctors on hand. When I remember these rural hospitals when I was younger, they would be full of doctors. And now to know that there's not even a doctor on hand is a stark contrast to what we think exists in a hospital if you're not in the hospital all of the time. So we'll, like I said, continue to have the
thank you.
discussion. Thanks.
Any other questions for the senator? Seeing none. Testimony in favor. How many do we have? Okay, quite a few. All right, come on up. Please fill out a witness form as well. And the rest of you, if you can make sure your cell phone is off or on vibrate, it'd be much appreciated. Thank you.
Thank you for having me. My name is Jordan Gibson. I'm a physician at a rural hospital in Bolivar, Missouri. We're 35 minutes north of the closest level 1 trauma center. We serve 8 counties. I'm here speaking in support of this bill, 520. I feel this bill is critical because it ensures hospitals with emergency departments have at least one physician on site to lead the team at all times. This helps to safeguard Missourians, making sure they receive the highest standard of care, regardless of where they live. The emergency department's a unique environment in medicine. It's often the decisions and actions that are taken in the first minutes after a patient arrives to that emergency department that can make a difference in their long-term outcomes, whether they live or die, whether they are functional or not. I can tell you from my own experience, I work overnight and I'm single physician coverage. You never know when these patients will arrive, but you need to be ready for them when they do get there. I would like to share you, this is a very recent anecdote, I've got multiple, but this happened in February of this year. A 2-month-old, previously healthy female was brought in by her mother. Her mother thought she was acting fussy. Right around midnight, the baby came in, we checked her heart rate, it was beating at 280 times a minute. The baby was obviously in distress, and she needed immediate actions to be taken and expert level of care. So I assembled a team to the room, multiple nurses, respiratory therapists, and we started to take interventions. When you're taking care of a 2-month-old, it's difficult. They're small. The medications you need to give them, the interventions you need to do are not the same as for an adult. So we had to make sure that she was receiving the appropriate interventions for her size. You know, getting vascular access in a 2-month-old is difficult. Their veins are teeny tiny. We had to place a line into her bone to give her medication. We had to give her the appropriate dose of the medication to try to slow her heart rate down. When that was not successful, I needed to put pads on her chest and deliver an appropriate amount of electricity to shock her heart out of the dangerous arrhythmia. If she was actively decompensating during this process. She was going into shock. She was dying. Her oxygen levels were going down. And after we shocked her, we stabilized her. And within 26 minutes of arrival, this baby went from a kid who was actively dying to she was on the mend. At that point in time, I had to arrange transfer. You know, when you're transferring patients from a rural hospital to a higher level of care, that can sometimes be difficult. Sometimes that can take an hour. Sometimes that can take 8 or 12 hours, depending on what's available to you. That night we were lucky, and we were able to get this baby to Kansas City to Children's Mercy. She saw a cardiologist that day. She got put on medications. I had the ability to follow up, and she's doing great. She's going to live a long, full, happy life because she received expert, timely care that I believe is higher level than what a nurse practitioner or a physician's assistant have really received the training to be able to administer confidently and comfortably. And so, you know, and she was able to receive that timely, more timely than a physician could be expected to come in from home to be able to provide that care. So, you know, the emergency physicians, we are uniquely trained to be able to make these decisions and make these actions in a timely fashion. And just to kind of, you know, we found that patients want to see a doctor when they come to the ER, especially you would want your 2-month-old daughter to see a doctor if she was dying in the ER, if you could. When people come to the emergency department, they want to have confidence in the care that they're receiving. And so Senate Bill 520 ensures that Missourians have access to the gold standard of physician-led emergency care. This legislation is not a luxury, it's a necessity to protect patient safety and maintain public trust. So thank you for your time and consideration. I'm happy to answer any questions you may have.
Yeah, thank you, Doctor. Appreciate it very much. Is there any questions for the witness? Seeing none, thank you. Thank you very much. Appreciate it.
Thanks.
Next person in favor? Do paper, rock, scissors. That'd be fun.
All right. Mr. Chair and members of the committee, I'm Dr. Michael Mullins. I'm a practicing emergency physician in St. Louis, Missouri for the last 26 years. And I'm stand here I sit here in support of Senate Bill 520. I want to thank Senator Carter for bringing this more important legislation forward. So, walking in today, I can't help but to notice the Salus Populi Suprema Lex Esto inscribed in stone across this building. Your service here in the Senate and this committee in particular affirms your endorsement of this ideal. It's the same ideal that calls me here today. So the bill, as you now know, will ensure that there's a physician in every emergency department in the state. And we know from research in the Journal of Nursing Regulation that the nurse practitioners are not yet a substitute for this. The training varies widely from 3 credit hours, which is like a 1 semester course, to 12 or 15 credit hours, or it varies widely from institution to institution training nurses. So the authors of this paper, who were advanced educated nurses, not a physician among them at all, concluded that at this time, nurse practitioners should not be the independent, unsupervised sole providers of care in an emergency department. I fully agree with that. And on behalf of my organization that I represent, Missouri College of Emergency Physicians, we fully concur. So the cost keeps coming up of the hourly or salary cost for nurse practitioner versus a physician, but as Senator Carter has already abundantly made clear, similar, demographically similar urban, rural, suburban states, Indiana and Virginia, which share characteristics with Missouri, passed similar legislation without closing any critical access hospitals. I'm confident that we will do the same. So from my standpoint, patient safety comes first, and we should have a standard that matches what our patients expect, because when you're in an emergency, you can't pick a hospital often without leaving your county. I want to draw on Senator Nuremberg had a question earlier that reminded me of something else about the pre-hospital care. For decades, we've trained EMTs to a standard, and we have accepted nothing less. Whether you're in a big county or a small county, EMTs all are trained to the same standard, all have the same training. So if I am in a car wreck in Jasper County, Ozark County, I know that the EMT is going to come to me, has the same training as one that come to me in St. Louis County. So I think we should follow that and have the same level of standard for the hospital care that follows when the ambulance arrives at the hospital. So I thank you very much for your attention. Thank you very much, Senator Carter.
Thank you very much. I appreciate it. Is there any questions for the witness? Seeing none, thank you, sir, very much. Appreciate it.
Thank you.
Yep. Next in favor.
Good morning, Mr. Chair and members of the committee. Thank you for the opportunity to testify today in strong support of this bill. My name is Kene Chukwuanu, and I am an emergency physician and an ICU physician at St. Louis University Hospital and St. Mary's Hospital, where I serve as the Associate Residency Program Director for Emergency Medicine Training of Physicians there. I am here not only on behalf of myself, but I'm here on behalf of my colleagues in the Missouri chapter of the American College of Emergency Physicians, and on behalf of our countless patients whose lives depend on the decisions made in the emergency department. I want to talk a little bit about that journey that a patient has through the emergency medicine process. Before a patient even arrives at the emergency department, their journey begins with the EMS crews, the real frontline first responders in life-threatening situations, and they need to know that the facility they're taking a patient to is adequate and fully prepared to accept that patient. Imagine yourself as an 18, 19-year-old or a young, newly graduated EMT or paramedic. You're transporting a patient of shortness of breath to a CCD level facility. En route, your patient is laughing and joking with you, and then suddenly and unexpectedly codes. You're performing CPR in the back of an ambulance down the highway, trying to get to that facility, but because this patient is now critically ill, you can't reach that TCD facility, and you stop off at the nearest hospital, expecting that the physician that you drop the patient off to can take your patient and save your patient. Now imagine if that patient in the back of that ambulance is your mother, your father, your spouse, or God forbid, your child. EMS crews should never have to question whether there's a physician on duty and whether that facility is equipped to take those patients. The moment a patient walks into the emergency department is the most critical moment of their care. I see this as an ICU physician. If things are delayed in the emergency department, it makes our job harder and it makes the patient's recovery worse. From the second they present to the emergency department, they deserve physician-coordinated care. Physicians are uniquely trained to synthesize complex information, make high-stakes decisions, and provide the best possible outcome for those patients. Without a physician on site, critical time can be lost, and this bill ensures that there will be a physician on site for that. This also contributes to burnout. When physicians are not in charge of the emergency room, the entire care team suffers burnout. And so this prevents that. Patients are more likely to receive timely and appropriate care. Health workers that we know in a critical crisis in this nation, burnout, benefit from a coordinated and well-led care team. This bill is vital to ensuring that emergency departments have the highest standard of care from when a patient arrives, and that EMS crews can deliver patients to a ready and capable facility, and healthcare workers can also thrive. As a residency program director, our trainees train under the highest standard, which is that a physician is on site, on duty, and that there's a physician-led care team. Without this, we lose the thousands of medical trainees, doctors that already train in this state because they expect that highest standard of care in their practice. This state can't afford to lose its physicians. Our communities can't afford it. Our patients can't afford it, and our loved ones can't afford it. I urge you to support this bill and protect the lives of patients and the well-being of its healthcare providers. Both you and I are called by our state's motto that was previously mentioned by Dr. Mullins: the welfare of the people is a supreme law. Thank you for your time and consideration, and I'm happy to take any questions.
Thank you, Doctor, very much. Appreciate it. Any questions for the witness? Thank you, sir. Next in favor.
All right. Good morning, Mr. Chair and members of the committee. Hello, my name is Dr. Rob Poirier. I'm an emergency physician at Barnes Jewish Hospital, WashU School of Medicine. I've been the clinical chief of our emergency department for over the past 20 years. I've also been medical director of our nurse practitioner and physician assistant group, building it from 8 NPs and PAs up to over 30, and been involved in their training. And so I want to express my strong support for the Senate Bill 520, representing myself and the Missouri College of Emergency Physicians. We've heard many arguments today why this bill should move forward as written. Patients want a physician present and expect a physician present. I would want it for myself or my family or friends, and I believe you would too, especially if you are having a time-critical emergency that needed immediate diagnosis and intervention. We've heard that critical access hospitals would close, and that's a concern that we've heard and has been made definitely in Virginia and Indiana, and we have those states to look at now. And when a similar bill went through in those states, no critical access and no rural hospitals have closed. Indiana has a larger number of rural and critical access hospital count than Missouri, and Indiana put through a similar bill in 2023, and still no critical access or rural hospital closures. According to a recent Becker Financial Management report, Missouri has 20 rural hospitals, or about 34% of our hospitals, that are at financial risk of closing sometime in the future, and maybe 17% facing immediate financial threats, which means potential closure within the next couple of years. Virginia and Indiana are down at 10 to 15% of hospitals, and their percentage of hospitals at financial risk have actually decreased since they've put a similar bill into effect. So having a physician present can improve financial performance. It also impacts, physicians, the way they prescribe and what they prescribe impacts the 340B reimbursement, which we know our critical access and rural hospitals depend on for financial support. The finances of critical access and rural hospitals are very complex, but we've got the SHIP grants, or especially here in Missouri, the small hospital improvement plans funded by HRSA. We've got USDA grants with some ARPA support there, Medicaid, Medicare, and Medicare pays at cost and plus at the 105% level. And we have 340B. So I think having a physician staff model can be successful, as successful here in Missouri as it has been in Indiana and Virginia. And I don't think we would see closures, and maybe the financial status would improve as these other states have seen. And previous surveys, Virginia and nationwide, have showed anywhere from 80 to 97% of citizens believe when they present to the emergency department, they deserve physician-led care. They want the physicians who have 10 to 20,000 of hours of experience. They're present versus whether it's nurse practitioners or PAs with anywhere from 500 to 2,000 hours of experience. And so, and there are multiple solutions out there to covering rural hospitals and critical access hospitals. You can have shared FTEs, just to name one, and it is important to provide competitive wages and packages to attract the physicians to the hospitals. Rural patients definitely deserve a highly trained physician when a medical emergency arises. Having been on the receiving end, so I receive transfer calls from rural hospitals and critical access hospitals fairly regularly, probably hundreds or thousands over my 20 years. And I can hear the panic in the voice of especially our nurse practitioners and physicians assistants out there working alone. I also have to be more detailed and give them very specific, I have to ask a lot more questions and give more specific details on how to manage that patient and how to get the patient over to us. And right now we're seeing EMS capacity issues. EMS is delayed. The helicopters aren't flying because of weather. And so the patients with critical illness are stuck in these rural access, critical access hospitals for hours. And it's extremely important that the personnel there know what to do to limit the effects of these critical illness, whether it's severe trauma, head injury, brain bleeds, heart attacks, strokes, aortic dissections, can go on and on. Some patients have died because the time critical interventions were not provided. And so I think having physicians there will improve our ability to be able to perform these time-critical interactions. Not having the higher level of resources present increases the stress and tension at these rural access, the rural hospitals and critical access hospitals, and it increases the turnover because physicians, nurse practitioners, and PAs, when you talk to them, say it's too stressful, I can't work there. And that also impacts your ability to hire into that organization and provide the care you need. So would we run an operating room without a surgeon? Should we run hospitals and EDs without a physician? I hope you believe in your heart on behalf of providing quality care to all citizens of Missouri, most especially our rural citizens, that you will support Bill 520. I have faith in Missouri and believe that the financial conditions of our rural hospitals can improve with physician staffing. You know, emergency medicine is a very complex skill that requires comprehensive training and expertise. Passing this bill will save lives, and patient safety must come first for our citizens. I'd like to thank Senator Jill Carter for sponsoring this bill, and I'm happy to answer any questions.
Thank you for your testimony. Is there any questions? Yes, Senator Lewis.
Good morning,
Good
Doctor.
morning.
How are you?
Good.
Good. Thank you for testifying. Have you been to the Capitol and testified before?
Oh, yes, several
Okay,
times.
good. Well, thank you. Just a couple questions for you. With Indiana and Virginia, do you know if they have physician shortage in those two states?
They do.
They do. Okay. Because I'm sure you're aware, here in the state of Missouri, the majority of the counties are considered healthcare deserts with a shortage of healthcare providers. And we've done a lot of work, to try and recruit and get physicians to work in rural areas. So I was just curious about what the landscape of the other two states you mentioned. And how long has Indiana and Virginia had this type of legislation in place?
Yeah, Virginia, I believe since 2021 or 2022, and Indiana since 2023. They had many physicians in their critical access and rural access already. They had physician shortages, especially Indiana and Virginia, but they've solved to it. You know, we have these national license compacts now for physicians, so we can go into multiple states and not go through the extensive reviews to get our licenses. You can move around a lot. So really it's about supply and demand, and physicians will work in a hospital that they feel has the resources to support them to provide the care that they want to prepare to give, and then also at a level that they expect to give. When you're providing care below the level you were trained to, or you feel comfortable, if you feel it's not as good care, you're more likely not to want to work in those areas.
Okay, yep.
And so I think it's important we can deploy some of those measures. I think there are ways Missouri could do better to attract physicians to their healthcare deserts like other states have done.
Yeah, good. Okay, well, thanks. And I think that a couple of things I just want to point out and make mention. You talk about the medical licensure compact, which Missouri is part of. However, in another committee I've heard, we've had other bills to try and expedite because there's still a backlog with getting physicians licensed here in the state of Missouri. So the reality is they're not able just to get licensed like that. So that's not how it works here in Missouri, unfortunately. And I was a sponsor of the medical licensure compact a couple years ago. So I do want to expedite the process, but that's not what's happening. I also want to thank you for mentioning the 340B program that is vital to our rural communities. And I want to point out to the committee that in Senate Bill 336, which we just voted on, that was gutting the program here in the state of Missouri. So thank you for being here.
Any other questions for the witness? Sir, I'd like to ask you a question, if you don't mind. I have a graph here in front of me that's from 1975 to 2010 that admin growth in healthcare has severely outpaced patient or doctor growth by over 3,000%. Can you speak into that at all?
I would agree. I've seen that happen. You know, as healthcare finances, running the hospital, running logistics, inventory, dealing with pharmaceutical companies, dealing with insurance companies, you have to layer in now. We've made healthcare so complex in the United States, not just in Missouri,
Right.
that you have to layer in as the insurance company and pharma layers in more administration, you do too. I work clinically 10 to 20 hours a week, seeing the rest of my time is administrative, managing our group. I'm also a physician advisor for our hospital, and I'm doing peer-to-peers to negotiate to get payments for patients we've already treated. But I agree, the administration within hospital, and it's all due to the complexity with which we've layered on healthcare, and that's a national issue. But
Right.
we need to start working on that because we need to get care back to the patients.
Yeah, I
and
would certainly
focus on
agree
the
with
patients.
that.
I
Yeah.
agree with that.
Yeah, thank you very much. Appreciate your testimony. Thank you. Any other testimony in favor? You can leave your. Do you have a witness form too? Did you leave?
Yes.
Okay, perfect.
Brief. Mr. Chairman, members of the committee, Jacob Scott with the Missouri State Medical Association and the Missouri Osteopathic Physicians and Surgeons, just going on record in support of the bill. I think the committee needs to invoke, and the hospitals need to invoke a little wisdom of Dave Ramsey and prioritize and hire more physicians for their emergency departments because that's what patients expect. We know that from all the surveys that have been done. They expect to see a physician in the emergency department. Happy to answer any questions.
Thank you for your testimony. Any questions for the witness? Thank you very much.
Lisa Panett with Armorvine. I think if you would conduct a survey of the people in Missouri, the regular people, that you would get an overwhelming response, probably close to 100%, that they would believe that there already is a physician in an ER. And along those lines, I think if you would then ask them, would they feel comfortable going to that ER if they knew that there wasn't a physician present, they would probably say no. And that is why we're in favor of this bill.
Thank you very much. Any questions for the witness? Thank you. Appreciate it. Any others in favor of this bill? Any opposed? Please come on up. Appreciate it.
Wherever. Pick your poison.
Thank you.
And whenever you're ready.
All right, thank you very much. Madam Chairman, Mr. Chairman, John Doolittle, President and CEO, Missouri Hospital Association. And I feel like I need to start, especially with the good docs right here behind me. The Missouri Hospital Association, John Doolittle, nobody is making an argument that physicians and mid-level providers, nurse practitioners, and PAs are the same. So I want to make that perfectly clear and show my respect for the folks behind me. I've been in this role for 3 years. Before that, for 11 years, I was the CEO of my hometown hospital, which is a critical access hospital in Albany, Missouri, population roughly 1,752 after the Doolittles moved to Jeff City. There are few things that I know more about or care more about than running a rural emergency department. I was there on a Monday night when my father-in-law walked in with cardiac pain, and it had to have my hospital ready to care for him. When my son went down with a severe problem at a football practice, it was my emergency department that brought him back to life. I would say that I was very typical in the fact that as a rural hospital administrator, I did everything I could to make sure that my organization was ready to provide life-saving care. We often, not always, often had a board-certified emergency department physician in-house, and that was our preference. It was our preference. It wasn't possible for us at all times. So then what do? If you are running a rural hospital and you don't want to close your emergency department, which you can't have a hospital without an emergency department, CMS is quite sure of that. And so what do you do to make sure that you're able to provide that high level of care? The state of Missouri has a time-critical diagnosis program that provides rules about how ready teams need to be for traumas, for strokes, for STEMIs. If a hospital can't be certified in those areas, the ambulance crews know that they need to bypass those hospitals. But those regulations that are in place today do not require a physician to be on site, seated or standing in a hospital, ready for the next person to walk in. My hospital had an average daily census in the emergency department of 7. Bolivar is somewhat rural. It is not typical. It's not a critical access hospital, and it's not typical of the critical access hospitals in the state. So again, what did we do when we didn't have a designated board-certified emergency physician available to us? Our family practice physicians, who were ACLS certified, ATLS certified, otherwise trained and worked all the time with their care teams, would cover the emergency department. With an average daily census of 7, it is not the best utilization of a rural physician's time to have them sit in the hospital ready just in case something walks in, when they can be in their clinic across town seeing 30 patients and can be at the hospital in, I would say, 5 minutes. I know they've done it in 2, right, in real emergencies. But what we're talking about here is a preference and I think a solution that's kind of in search of a problem. Most hospitals have, if they're of any size, they have physicians in-house. And those physicians are responsible for the emergency department. So this requirement, I don't think, would change the way most of the hospitals in the state operate. It's really targeted, I think, at changing practice in some very small hospitals that may not have a better answer available to them, and so they construct answers. They use creativity, they use telehealth, they use family physicians who are trained in emergency medicine, who would not put their licenses on the line, I promise you. I was there for 11 years, to be asked to do something that they weren't qualified to do. But this very simple legislation, and I applaud the simplicity, and I know your heart's in the right place. I know it is. This is kind of the unintended consequences express, right? Dr. Angela Martin is my doctor. Dr. Martin had 3 daughters. Dr. Martin would cover our emergency department for a 24-hour period on Tuesday and also see patients in her clinic. And if one of her girls had a softball game 3/4 of a mile away, she could go and stand in the outfield and watch one of her daughters play softball, knowing that if something walked in the emergency department, she could be there in 2 minutes. That's good design. And if we're worried about getting providers and physicians to go practice in rural areas, we need to give them the flexibility to have a high quality of life so they'll stay there. Thank God Dr. Martin is still in Albany taking care of people. I don't know what we'd do without her. She could work anywhere. She chooses that lifestyle. She chooses to provide those services in our hospital. and we're able to afford her the flexibility to have a decent quality of life and still be absolutely responsive to any emergency that comes in. My physician, I would like to say colleagues, I don't know, I hope they would consider that, listed a number of things here I feel like I need to speak to very quickly. Number one, financial stress. 2022 was the worst year for hospitals in recorded history financially, so the fact that some have seen improved financial conditions since then, I would believe is coincidence. It has nothing to do with the fact that in a couple of states, but not yet Virginia, that they've been required to add physicians. The Virginia law passed, it goes into effect July 1st of 2025. So I think it would be kind of a rough argument to say that this is already in place and nobody's closed. I don't think it's in place yet. And please double check me on that. But my quick Google search on the Virginia law, I hope I didn't misspeak, the Virginia law. Indiana law went into effect in 2023. There were a couple of rural hospitals that closed just before the law went into effect. But I'll tell you, if you're trying to take care of people in any community, but perhaps particularly a rural community, you're going to fight like crazy to keep yourself open. And you're going to make adaptations. But what I think you don't want is an unfunded mandate to change the way that you've been taking care of folks for a long time in ways that must be satisfactory to those local communities, or those hospitals wouldn't be in business. Everybody in a town of 2,000 people knows how the hospital works. They see the providers in the grocery store. And so I think this is well-intentioned. I think it's a little too much of a blunt object, and I think it's really ripe for unintended consequences. Even the American Medical Association, who has introduced this sort of model language, in its own document about this says it wouldn't be appropriate for the AMA to think about exceptions for rural areas at a national level. So even the AMA, when it makes the case for this law on a state-by-state basis, acknowledges that there should be flexibility and potentially exceptions made for rural care. So I'm trying to help with a number of the things that have been said and tell a little bit of a story here. I hope I'm not rambling too long. The last thing, it was cited, I do know a lot about hospital finance, having run my hometown hospital for 11 years and fought like crazy to keep it open to take care of my family and friends. Cost-based reimbursement that was mentioned before for critical access hospitals, it's not set at 105%. It was set at 100%, 101% of allowable costs. Not all your costs are allowable. And that's only for Medicare patients. And the problem is with sequestration at the national level, you take a 2% hit, you are by definition losing money on every Medicare patient that comes into a hospital. There is surely no end in sight to sequestration at the federal level. In fact, most of these hospitals are bracing for cuts in Medicaid and other programs that allowed them to stay somewhat sustainable. 53% of the hospitals in Missouri ran a negative operating margin last year. So we are going to be, if we go forward with this, adding pressure, adding regulatory burden, which leads to more administration. Your question was very fair. Why has administration grown? It's because these businesses, and they are businesses, like it or not, they're incredibly complex. Everything has to be there, ready to take care of people. You need a professional staff to make sure they're always ready. And every time we add a regulation, we add a need for more administration. I really wish healthcare could be as simple as it was in the past. I have tremendous respect for the physicians that spend their time saving lives. I've seen it. Having a board-certified emergency department physician in my hospital gave me great comfort. There were a number of times that I couldn't do it, and it was not the best way for me to serve my community to close down. Thank you for your time.
Thank you, sir, very much for your testimony. This is a loaded question, but I want to ask you it anyway, since you have worked, especially within the financial area of the hospital. What's causing the high cost? What's the burden of the high cost? Yeah, I told you it was loaded.
Yeah, no, I have a days-long presentation that I could give on this. I'm going to give you one line. Hospitals, like any other industry, have to pay for supplies. The costs of every single supply in a hospital, roughly 60% of which are people costs or human costs, continue to increase faster than the reimbursement increases, right? For hospitals, and particularly for rural hospitals, an overwhelming majority of their patients are on Medicare or Medicaid. Those are government programs where, by design, reimbursement is not rising as fast as expenses are rising. And that's why people seek to manage expenses, because if you can't make payroll, you can't take care of people. But it is the cost of pharmaceuticals, medical supplies, and people. And everybody wants to pay their folks a fair wage. But we have seen extraordinary inflation, as you know, in a number of areas.
Right. So you would agree, too, that the administration bloat, that from the graph that I quoted, is part of the problem as well?
Oh, no question.
Okay.
No question. I don't know of any hospitals that are seeking to add payroll expense.
Right.
What we hear very commonly is folks are looking for ways to increase the value of their care, which is higher quality, lower cost. And quality doesn't happen by itself.
What about certificate of need? Does that factor into it?
I don't see that certificate of need drives cost in any way.
Okay. Thank you for your testimony. I appreciate it.
Yeah, thank you.
Any questions for the witness? Senator Nurnberg?
Just very briefly, I really do appreciate the conversation today, both from the physicians who gave their time. I learned stuff from you all. I really appreciate, especially your work in training the next generation of physicians, and really applaud your efforts. And I appreciate you being here as well, and really sharing that what this ultimately is an unfunded mandate. And I feel anytime, and I've only been in the General Assembly for 5 years, but typically it is nice when we're doing something that is more or less novel to see how it plays out in other states. And right now that only one state has had this for a couple of years, just the state of Indiana, and if that's the case in Virginia, soon to implement or to go into effect. It does cause me a bit of pause. And one of the things that I've taken away from the conversation today is if we would have some sort of carve out, at least for now, for our critical access hospitals. I understand probably the senator's original intent that she wants to make sure that area near her, but again, recognizing how important in our communities that we have our primary care physicians that are able to use their time to administer and spend their time with their patients doing primary care, to make sure that they're on the proper medications, they are taking their blood pressure medicine every day so they never have that stroke in the first place, right? Instead of spending the time with a census of maybe 6 people in a hospital during the day. Recognizing, again, every community is very, very different, right? So appreciate everything that has been shared today, and we'll see where this goes from here.
Thank you, Senator.
Thank you. Yes, Senator Lewis?
Good morning.
Good morning.
I just want to kind of point out too about the one physician who explained the heroic measures to save the 2-month-old. So that was
It's fantastic.
fantastic story. I think also that when you work in healthcare, and I didn't work in the ED, I worked in the ICU in a trauma center, but I was in code blues every single day. I heard code blues and bells and whistles in my sleep. So that's we have I'm RN BSN, but I was ACLS certified, TNCC certified. So when we talk about like the level of training that whether it's a physician or respiratory therapist or nurses or anyone in the healthcare team, we have special training to go into these code blues, and when you see it day after day after day, it's kind of like you do it in your sleep. And when we talk about a physician physician, I think of like having a urologist or a radiologist, not to downplay their education and level of training, but I don't think they would be well equipped to handle trauma situations because they don't do that in their day-to-day activity. So when this says physician, we've got different levels. Oncology, for example, amazing at curing cancer and treating cancer, but probably wouldn't be their best use of their time to be in an emergency department, nor would it be a good service for the people that come there, because it's just because it's a physician but not trained in that area. So just wanted to bring that up.
Yeah, it's as I said, we're all drawn to simple. The simplicity of this is what probably makes it undesirable from an unintended consequences standpoint. The other point that is true here, access to care, and the physicians know it better than I, but We were a level 3 drip and ship stroke center. Again, we normally had a board certified emergency department physician in-house. Sometimes we didn't, right? When Jeremy Hunter's father passed away and he had to leave, Dr. Miller could say, I'll cover for you, get to your family. She didn't cancel the rest of her day in her clinic, but she was covering the emergency department, right? Unfortunately, there were times that we staffed with physicians who we didn't know all that well. And sometimes we learned the hard way that that wasn't a physician that we should bring back to our ER. Again, this has the potential for a fair bit of unintended consequence when we create demand for a solution in a shortage area. Not only would it drive up cost, and it would, but it also could inadvertently lead to a decline in quality or readiness in some cases.
Thank
From my
you for that.
experience.
Thank you. Any more questions for the witness? Thank you, sir. Appreciate
Thank
it.
you, and thank you.
Any more here to testify in opposition to this bill? That's good because we're completely out of time. No, I'm just kidding. Senator, would you like to make any closing remarks?
No, I appreciate the comments and the testimony that was given and shared today and the comments from the committee. I just want to say, as the chair of the committee, that what I see happening with healthcare, and I think you all agree on this, is just not acceptable. We are in a crisis, a medical crisis, in my opinion, and I am, especially when it comes to this committee, and I've said this before, but I'll say it again. This committee touches more aspects of every Missourian's life than any other committee, I think, in regards to day-to-day life. And so the goal is to always have hard, honest, transparent conversations as we move forward. But as we do so, my intention is to try to unpack some of these heavier issues. This is one bill that's a compromise of a whole different kind of conversation that we need to be having, and so it is one that I felt like it was critical to have. Again, I think, to your point, Senator, that seeing medicine be administrative. My chief of staff, his wife is a doctor, and most of what they do is check boxes every day. And so they're not taking care of patients. What they're doing is making insurance companies happy and the government happy. They're not in the field doing what they're doing. And a lot of them are fleeing, just like we see with education, with teachers and everything else. It's more administrative instead of going into medicine and actually doing what they're, the passion of their heart, so to speak. So thank you for your time and testimony, and we'll continue to have these conversations. Thanks.
Thank you, Senator, very much. And everybody was here to testify. Thank you so much for coming and taking time from your day. Those of you who are in the building every day, thank you too for being here.
All right, with that, we're going to hear Senator Schnelltein's Senate Bill 525. Just begin when you're ready.
Thank you, Madam Chair, members of the committee. Senator Adam Schnelltein, representing Eastern St. Charles County, here to present, as Madam Chair had mentioned, Senate Bill 525. Thank you for the opportunity. This legislation is a step towards helping to alleviate the foster care crisis in the state of Missouri that we have by providing an additional layer of protection for kids and through a public-private partnership. It establishes a qualifying association, a citizen board, and with appointments by the governor, and a process by which to conduct oversight of Christian children home or religious children's homes with religious exemptions. The oversight of the qualified association in the bill is provided by the Child Protection Board that would be created within the Department of Social Services, with the citizen members of the board appointed by the governor, as mentioned a moment ago, by and with the advice and consent of the Senate. I think each one of the senators on the committee know and understand that the foster care crisis that we have in Missouri, our system is overburdened. But we also, I know each one of you, each one of us believe that every child deserves a loving and a nurturing and a stable home environment. This bill would allow religious children's homes to help provide that for Missouri kids, while also maintaining their religious exemption. I do have some experts to testify here today, and I know that we're running short on time, so I will just open myself up for any questions and then allow some additional testimony to provide further context.
All right, great. Any questions for the Senator, go ahead, Senator Herrenberg.
Morning, Senator.
Morning.
Thanks for being here. Okay, so I started taking a look at your Senate bill here, and I'll be honest, my first reaction is, isn't this undoing what we just did a couple years with tremendous bipartisan support, bicameral support, and with passing the guidelines for the boarding school law? I mean, I remember that was one of probably the most intense conversations in my first year in the
Yep.
House of Representatives, and Senator, I remember at the time you were just a couple rows down from me in that chamber,
yeah.
right?
Yeah.
And the stories that came out are nightmares of,
Yes.
of the trauma that people
Absolutely, the
experience
kids
in
have gone
those.
through, yes.
I remember listening to the survivors, a survivor from Agape,
Yes,
share their story. And those are the heart-wrenching stories that I hope nobody
they are, yeah,
will ever have to experience.
100%. I totally agree.
So I appreciate, one of the things that you said in your opening comments is all of us care about kids,
Yep.
right? We say that frequently. We come at things from different places, but I really believe, right, in my heart of heart, that all of us really believe in doing what we can to protect kids. And I you said that this is about doing what we can to help, unfortunately, the far too many kids we have in foster care in this state. But Senator, my question is very simple. Why not be licensed?
Good. Thank you for the question. We have homes in the state of Missouri that operate under religious exemption right now, so not every home has to be licensed. What this bill does is it elevates the standards, because now those homes that do have religious exemptions and that do have that do take care of children can apply to that qualified association and then be provided with oversight through DSS, through the Child Protection Board. So this allows for them to do that. So it's an additional layer, whereas right now they don't actually have to have that.
Okay, but I think it's absolutely imperative that we can have oversight from our state agencies that can come in and check and just see what's going on, get an extra set of eyes on kids. Senator, as you know, we have so many boards and commissions all over the state, and I know that there's efforts to take a look at those. However, we have hundreds of vacancies on boards and commissions. We create stuff all the time through statute here, and the governor has yet to appoint people. So I don't think there's any more important job in this state than the folks in Children's Division. I really don't. I think they are doing the most important work in the state. They are there to be, quite frankly, the voice and the advocate for the voiceless, and those jobs are absolutely imperative. I don't want to do anything that gives any sort of authority of folks on a board that, again, I thank people that serve on boards. Obviously they're unpaid many times and kind of thankless tasks, but also we know that so many of these boards are not filled, and and people have a lot of commitments that are placed on these boards, and they might not actually have the time to oversee stuff. I have a board of elections in my county, Senator, that unfortunately people have been serving on expired terms for far too long, and some really egregious stuff was happening that nobody was actually paying attention to, right? So what I can say is, I think, and I trust that you're coming from a good spot with this, but based on the horror stories that played out in our state for far too long, this General Assembly took a really bold move and said, we got to do something about this. And it was through a lot of hard work and really listening to those survivors and saying, what can we do to ensure that this never happens again? And that's what we did with the boarding school law.
Yeah.
And I don't want to do anything that infringes on the work
Yeah,
that we've
sure.
done.
Yeah, I can understand your concerns there. I think there may be a fundamental misunderstanding of the bill itself. This does not take away the authority of DSS. They still retain their authority. The board makes recommendations to
So DSS can pop in at any time.
DSS can, yes, the state can still provide inspections at any time.
Okay, well, I know there's probably some folks who will testify, and we can
Yeah.
continue the conversation. So thank you, Senator. I
Yeah,
appreciate
no,
it.
absolutely, absolutely.
Any other questions for the senator? Thank you, Senator.
Thank you.
How many people are here to testify in favor? Any opposed? Okay, thank you. We'll begin with those who are in favor. First, in favor. Just come forward. Make sure you fill out a witness form and leave it on the table.
Good morning. My name is Chad Puckett. I am the Executive Director at Show Me Christian Youth Home, and I'm also serving currently as the President of the Missouri Association of Christian Child Care Agencies. And as Senator Schnelting has mentioned, there is definitely a foster care crisis. We, as an agency, the Missouri Association of Christian Child Care Agencies, in fact, we want to come forward to have a seat at the table and help where we can, again, at no cost to the state. We obviously know there is a crisis going on, and my ministry in particular and others represented here today have been doing this for decades, offering quality care to children. In fact, when I started my ministry at Show Me Christian Youth Home in 1997, half or more of our kids were placed with us by the state. We had a number of children that did very well in our program, and we were a good fit. We worked well with the state, had good rapport with them, have our own support services for the children in our care. In fact, I have two of our young people that grew up with us that are here to share their story. So again, what we're trying to do is not undo anything that has been done. We acknowledge that things have, bad things happen. Bad things happen in licensed facilities, bad things happen in unlicensed facilities. And what our goal is to minimize those, provide a process for ministries to retain their religious exemptions while adding a layer of support to the child care ministries that we serve. And that's really what the goal of this legislation is all about. Again, we're coming to the table. I am very encouraged. We do have an upcoming meeting with the new Department of Social Services, Social Services Director, Jessica Bax, as well as the new Director of the Children's Division, Sarah Smith. And we are excited that we can finally have a sit down, come to the table, discuss what we need to do so that we can again help alleviate the foster care crisis. And that again is our goal. We are not undoing anything. I'll be clear. We are not in opposition to any legislation that has been passed. We know that that was hard work, and we want to add to that a layer of protection again so that the state can trust our services to alleviate the foster care crisis.
Thank you. Any questions for this witness? Seeing none. Appreciate your time. Make sure you
Absolutely.
fill out a witness form and leave it on the table. Next in favor.
How you doing, sir? Good to see you. Good morning. My name is Mark Atkinson, Madam Chair. Thank you so much, committee, for allowing us to be here this morning. I want to echo the words that Chad Puckett from Show Me has shared with you. The one thing that we have a very strong passion about is kids, as everybody has already spoken about this morning. And I think the one thing that I want to stress is that what we're wanting to do is to be able to come alongside of the Department of Social Services to be able to make sure that, as the senators have specified earlier, the tragic stories and the victims of what has happened. That's one thing. I have been with executive director at Shiloh for 20 years. And before that, I was actually a board member for 5. And I have seen the bad players, the people that we despise as a children's home, because we strive so strongly to make sure that we put in place all the protections, all the administrative, the front line with our home parents that take care of the kids on a 24/7 basis. We do not want to alleviate anything that was passed with House Bill 557. Matter of fact, we came alongside, and I can tell you, I know Show Me and Shiloh were one of the very first license exempt organizations to get registered. I mean, we were right there. And even before 557 was passed, we were already doing background checks. We were already doing fingerprinting. We were doing all those things. So it was easy to come alongside. We just had to do the new protocol that the legislation entailed. Matter of fact, that's one of the things that the legislation we want to be able to do is for the longevity that like Show Me and Shiloh have had. We want to make sure that any other license exempt facilities within the state of Missouri are required to meet those high standards that the state has put in on the state side of licensure. We want to make sure with our association that those other homes need to meet those rigid standards as well. And the last thing we ever want to do is put any child in any of those situations that the senator brought up during that time of legislation 2 years ago. So that's what we fight against, and that's what we want to do, to be able to come alongside. And if there are openings that we have within our ministry that we can take a foster child that is at the mercy of overcrowding or whatever situation might be within the foster care system, that possibility would be there. And the other thing is, we just want to work and collaborate and be a willing participant in helping more kids. That's at the heart of what we want with this legislation. And I know Senator Shelton came and actually took a tour of our ministry and spoke with some of our kids. And that's one thing that the transparency, and I can speak for Shiloh, and I know I can for Show Me because I've known Chad and Show Me for a long time. We have transparency. I mean, anybody, going through the right channels want to come and take a tour anytime. Matter of fact, Senator Snelting came without an appointment. He stopped by. He said, "Can I take a tour?" Took him right out. And that's what we do. We do that all the time. So we want to be those flag bearers to show what it means to actually do things right. And we want to be part of that association to be able to do that. So I am very strongly in favor of this Senate Bill 525, and I would be happy to take any questions that the committee might have.
Thank you for your testimony and for coming today. Any questions for the witness? Seeing none, thank you again.
No problem.
Next in favor.
Good morning. Good morning to you, Chairwoman, and to all of you. I thank you for listening. I thank you for your research. I thank you for being part of this committee, and I thank you for your decisions. And I know that that's very important. My name is Denise Blue, and I was a house parent, a home mama for 40 years at Shiloh Christian Children's Ranch. And I am in support of this bill, but I have ideas on both sides because my husband and I always had a desire to take care of children, to do something, to be part of it. And when he got out of the Marine Corps, we ended up in Kansas City, and we decided to become foster parents. We went through the foster parent classes, had him check our house. We had a little house, but we were licensed for one child and emergency care. And living in the Jackson County area, we had many emergency children brought to our homes at all times of the night. They asked me to teach foster parent classes. I taught classes. I did that. I took part in things that foster care was doing at that time, doing the clothes closets, meeting needs for the kids and for families. But we knew there was something more that I wanted in this than just foster care in the part. And we heard a presentation about Shiloh Christian Children's Ranch, and we knew that was our calling. We knew that was where we needed to be. And so in a few months, we moved there, 1983. Lots have changed in this many times and eras that have gone by. Lots of things have developed, and Shiloh has moved right along with that, and so has Show Me and different ones. Yes, we watch over kids, we're with them, and in the early years, as Chad had expressed, we had foster care children that were brought to us. We worked with them, we went to the meetings, we were with all of them, and at some point they decided not to use us at all, and we still have kids that come from all around, all over the United States. Part of what we could do in this is move and maybe be able to help our foster care system also. I choose not to be state licensed, not that it's just my decision, but that's what I want to work with them. There are several things and steps that I have my opinions on. One of them is this: yes, we can say we all go to church together. Foster kids can, hear that word, can go to church, but when parents place with us, they know they will be going with us because we go as a family unit. We go as somebody that's going to take our children and go to church. We go through the Christian church because that's who we get financing from, individuals ones, because we don't ask the parents to pay anything. They don't have to give any money, and we don't take any money from the state. We are completely financed by people who care and share. It's pretty amazing, but we have a God that takes care of us in that. We have places for ones that need somewhere maybe for a short time, because we do believe in reunification. We will work at that, but we are not a place that says X amount of months and your program is over. X amount of months and we have to find somewhere else for you. X amount of months and you go to do something else. There's not that parameter put on it. We want some of our kids to know they have someone with them and they can stay. I've had kids come at 5 years old, graduated, got him through college, he has his master's degree, he's working a job, he has a family. I want them to know we're there to support them all the way through, that he didn't have to move because he had been in my foster care home for X amount of time. We have kids that know that they belong. There is something that gives a security and a foundation and a base point for them to build on in that. Now, are all my kids doing great? Absolutely not. Have all my kids that I've taken off to college, my husband, I've taken 22 kids off to college or tech school. Have they all graduated? Absolutely not. It's real stuff. There are difficulties. There are kids that may have to leave our program, but there are kids who have stayed and belong. And that's what we want from that. We want them to be able to have something, because if nothing else, if we can give them the ability to step into their adult life, to work a job, to pay on their bills, to find someone to have as a family, and stop the generational circle that we have watched happen. If we can do that, then yes, we've made a step in this. We've gone. 2 words I want to leave you with is accountability and availability. We want to be accountable, not just to our organization of Shiloh, not just to MACA, not just to the state. We want to be accountable to God for what our actions have been and will be. We try to watch very closely what that's going to be. The accountability we want, and availability. We want to be available to kids, to families, and to ones that need to have that support to make the next step in their life. And I want to show that with love and care and a consistency in their life that they truly, truly need. Thank you.
Well, thank you for your testimony today. Your passion is evident, I think, to all of us up here. And thank you for stepping up and trying to take care of kids.
Thank you.
Appreciate that. Any questions for the witness? Seeing none, thank you
All right.
again for your
Thank you.
testimony. Next in favor?
My name is Katrina Woods, and I would like to thank the committee for the opportunity to testify. I did not know my father as he passed away when I was 1.5 years old. After that, I lived with my mother and her live-in and out boyfriend, along with my 4 siblings. I had a rough childhood. I lived in poverty with no food at times for up to a week. My mother always seemed to find money for alcohol and cigarettes. There was a lot of physical abuse from my mother's boyfriend and sexual abuse from family members towards me. This affected me mentally and emotionally. When I was 8 years old, I found my mother dead in a chair at home and watched the EMTs work on her. For many years after that, I was passed around from family member to family member who never really tried to help me or talk to me about anything. I can admit now that I had anger issues and held a lot of resentment. I acted out and continually got abused by family. I was eventually dropped off at the door of the Missouri Division of Family Services after one such investigation when I was 16 years old. DFS placed me with the Show Me Christian Youth Home, and by this point, I didn't care about life. I was placed in my house with my house parents, and I had planned to end my life. I had heard other kids talk about how I needed to be baptized before I died, or I would go to hell. So I got baptized. I came back, sat on my bed with a knife. And I prayed one more time that God would, if this is where I was supposed to be, that what...
Just take your time.
If this was where I was supposed to be, that, and asked for a sign. Not a minute later, one of my house parents, Jennifer, came to my door and told me that she was proud of me and how glad she was that I was there with them. I had never heard words like this before, and this act of love changed things for me. Thank you so much. This act of love changed things for me. Show Me got me into counseling, and I was able to grow in my faith and graduate high school, which is something that I never thought I would do because I was so far behind. I learned what family really was, and I had a loving mom and dad. I met a fine man, fell in love, and my Show Me dad got to walk me down the aisle, which is every girl's dream. We have been married for 20 years. I went on to work as a police dispatcher and retired after 18 years of service. I now work for the Missouri State Courts at the local courthouse where I live. If it wasn't for the Division of Family Services decision to place me with the Show Me Christian Youth Home and Show Me's influence, I can confidently say I would not be here today to give this presentation in front of you. My life and my successes are directly affected by this decision. Thank you.
Thank you for your testimony. I know it takes a lot of courage to come and testify. Is this your first time coming?
I testified it at the, downstairs with the representatives.
Okay, for the same bill, same legislation? Anyway, thank you so much for coming. Any questions for this witness? Okay, Senator Nicola.
Thank you so much for coming today and sharing your personal story. It's heart-wrenching, but it's very encouraging at the same time. So thank you, because I know it's difficult to do that, but your story is very inspiring. So thank you. Appreciate you being here today.
Any other questions? Seeing none, thank you again for your testimony. Appreciate it. Next in favor?
Good morning.
Good morning.
My name's Aaron Moyer. I'm a former kid from Show Me Christian Youth Home. And I appreciate the committee for allowing me to share my story and my testimony.
I don't mean to interrupt, but if you would just speak a little
Oh,
clearer,
yes.
we want everybody who's listening
Absolutely.
to the committee to be able to hear you, so
Absolutely.
thank you.
Of course. My name is Aaron Moyer. I come here from Springdale, Arkansas. Made the little trip yesterday, so thank you so much for listening to me. I want to walk you on a little journey from before 2006 to now. I was placed in Show Me after my mother had lost her job in Little Rock, Arkansas. Show Me had come down and shared about what their ministry was. My parents were divorced, so we, for a season, did not have any income for our needs to be met. My aunt and uncle tried to assist, but Show Me was the best opportunity for us to be successful in life. When I was before Show Me, I had behavioral issues. I struggled with, I would do things such as punch holes in walls or not be able to communicate what my emotions were or share how angry I was. And so this was an opportunity for us to be in a safe and loving environment. In 2006, my group home parents took us in at Show Me and gave us some stability. So when I say us, my sister was placed there as well. And from that, we learned what good, healthy feedback looked like, what a relationship with Jesus looked like, and also what a family structure is supposed to look like. As I said earlier, I lived in a single-parent household, and I came to understand the importance of having two individuals that hear what we're going through, what we're thinking, or just to process things that we're going through. And so my group home parents became very important to me, and I stayed there for about 1.5 years with them. After about 1.5 years, I went back home. Show Me was still a part of my life, and they assisted me in going to college. I went to a small school in Joplin, Missouri, and that's how I ended up staying in Missouri for a season. I finished with a bachelor's in psychology. I was the first one in my family to complete a college education, and it's something I'm very proud of. I ended up doing some world travels, and Show Me supported me in that, where I got to help nonprofits around the world. And so none of this would have been possible if it wasn't for the fact that Show Me invested in me as a person, professionally and personally. They put people in my life that were mentors, that love me no matter what, who have carried my hurts and heard the deepest, darkest things that I've struggled with. And I can strongly say the person I am today would have not been the person I am if it wasn't for them being placed in my life. I now run a VOTEC school in Arkansas, and I have a family. I have a home, some things that I've worked very hard for, and financially, personally, emotionally, all of that came because Show Me saw me as a child and said, you're valued and that you can be successful. And so I'm open to any questions that you may have. On a personal note as well, my wife is Washington County which is where Fayetteville, Arkansas is the manager, the county manager over the foster care system. So this gives me an idea or an understanding of this situation personally, sitting with my wife and hearing what she deals with on a daily basis, on call, the finding the placement for a child. So I have an understanding of what that looks like a little bit. And I'm open to any questions from you guys.
Thank you. Thank you for your testimony today. I do have one question.
Yes, ma'am.
I represent Joplin in the 32nd District, and just want to know how we lost you to Arkansas.
Well, I was born and raised in Central Arkansas. I'm a diehard Razorback, and so
You can still be a Razorback fan. I'm just saying.
yes, and I graduated from Joplin, stayed there, worked in Pittsburgh, Kansas, and drove back and forth. But I love Northwest Arkansas. It's very beautiful.
Awesome.
But the Joplin was a great home to me as well.
Thank you.
Of course.
Again, thank you for the personal testimony. I know it takes sometimes a lot of courage to come and be so vulnerable with your own story, and so just thank you for that.
Of course.
Any questions for the witness? Senator Nurnberg?
Just real quickly, Madam Chairwoman, and thank you for being here. I really do appreciate this committee and how well you were able to run it, Madam Chairwoman, and have the conversations that we're able to have. So thank you. Just real quick, do we have to be out of here at 10 o'clock?
Yep. So
okay. So I just want to make sure, that
I
we
had
get
been
to
texting
opposition.
the senator. So.
Okay. Thank you.
All right. Any other questions? Yep.
Well, thank you so much for being here, sharing your personal testimony. It also is inspiring, and I appreciate it, so thank you.
Of course. Thank you, guys.
All right.
Yes.
Make sure you leave your witness form there on the table, and appreciate your testimony. We do have 10 minutes before we have to be out of here, and so I just asked, we're going to try to get through all of the testimonies here, so I would just ask that you limit your testimony to just a few minutes each, so that everybody who's driven so far has an opportunity to testify. So next, in favor? Right, there was only a couple left. No more? No, we've got it. Anyone else here in favor? Okay. Those opposed? Thank you.
Good morning.
Good morning.
I'll try to keep my remarks brief, and I'm happy to talk about this after today's hearing. My name is Jessica Seitz, and I'm the Executive Director of Missouri Network Against Child Abuse. We're the State Association of Child Advocacy Centers here in Missouri. I want to honor the intent of the agencies who've come here today to alleviate our foster care crisis. Our challenge as an agency when evaluating this legislation, this policy, is that we can not only guarantee that those with positive intent and practices, already existing practices that were mentioned here today, would be the ones taking advantage of the provisions of this. And we believe that there are two layers. They've called it layers of protection. I would say layers of risk that this bill establishes for our kids, where children can and have and will fall through the cracks if it's passed. We saw this with the horrific stories of Agape and other schools that led to the overwhelming, very careful crafting of 557 in 2021. I was involved in the passage of that legislation because of my centers in Southwest Missouri and all over the state who had served horrific cases of sexual and physical abuse of our children. And there was no accountability, no oversight, and kids got hurt. So there's an alternative to licensure embedded within this legislation that would empower a very broadly defined association, very vaguely defined on page 1, that doesn't have to have experience in child safety, doesn't have to have national accrediting standards or whatever. It's very vaguely worded. And they're empowered to provide that oversight of safety. It also, risk number 2, another layer, is that it establishes a board to oversee the association that is made up of a majority of those agencies and the association it's supposed to be providing oversight on, and no representation for the state, even though children in state custody would be authorized to be placed in these agencies. Again, I honor an agency who finds us a part of their ministry to serve these children. That's why the state currently has licensed long-term partnerships with religious facilities, Missouri Baptist Children's Home, Coyote Hill, and so on. So why alternative needed?
why additional layers? I have deep concerns, and 557 was very carefully crafted. We revisited this, we went deep into this 3 years ago in response to some real decades long, an issue that had been hidden for decades. I really urge your opposition and careful consideration of the provisions of this bill.
Thank you for your testimony. Any questions for the witness?
Thank you for being here. As I said, I started looking at this and I had just a lot of concerns, as I mentioned in the opening. And Senator Schnelting, thank you for returning too. Obviously I shared my original concerns, just knowing how much work we put into 557 to ensure that moving forward, kids never fall through the cracks again. And one of the things that you mentioned is that you felt like, while we understand, and I'm so thankful for the folks that are in these tough spaces, that do this tough work, that work to serve our kids. I mean, everybody that came here, I have no doubt that the work you are doing is so meaningful. Those of you who shared your experiences of how you were able, and it changed your life forever in a real positive way. So while many, and I would say the vast majority have a positive intent.
Yes.
We are also, if this legislation were to pass, there would be unnecessary layers of risk for the bad actors.
Yes.
Right? And I've been in a lot of spaces, right? Like I'm a cradle Catholic. I grew up in the Catholic Church, right?
Yeah.
I have so many stories I can share of unfortunately family members and others that I know, right? The vast majority of priests are really good priests. However, I know some really bad ones too.
Yes.
Right? So what I want you to speak to is a little bit is what specifically do you see the layers of risk being if this were to pass?
I see the layers of risk. So what we passed in 557 were minimum safety provisions on facilities seeking to remain license exempt, which means that children in state care are not placed in those facilities. They're allowed to remain private and their own governance and so on. This would allow for children to be placed by the state who've been placed in the care of the state, to be placed in these facilities with no oversight of the state, no licensure.
So there's no licensure. The senator had mentioned that he felt that DSS could still go in even though there wasn't the licensure for, visits, for inspections, et cetera. Do you feel like would that still be possible? I'm just curious.
I probably would rely on the state to think about how they would do that, but they wouldn't be allowed to be involved in the crafting of the standards that would make the agencies be registered.
Yeah.
They wouldn't be involved in that, and they wouldn't be involved in the board sought with overseeing the safety and the practices of the cases on the board.
And I know we're going to run out of time. And honestly, I saw the department here. I was hoping to ask some questions for informational purposes because I think that licensure piece is so important for us to understand what goes into actually obtaining a license, right?
Absolutely.
And so that's the part that if we're going to get short on time, but I really want to continue that conversation. There's a purpose and a reason why the licensures. There's and so we'll continue. Thank you.
Our system must, just to say, we work with private partners, right? That like religious agencies to take care of our kids. That's why we were, and so, but it's a partnership. You get a seat at the table. You want a seat at the table, you get a seat at the table as a part of this partnership and licensing. So I'm concerned about an alternative pathway. I'm concerned about an alternative pathway.
Thank you.
Thank you. I think we have one more person here to testify against, so we just want to give them a little bit of time. Thank you.
Thank you.
Thank you for your testimony, and make sure you leave your witness form on the table.
Hello, my name is Emily Van Schenkoff, and I'm the Executive Director of the Missouri Children's Trust Fund, and we are a statewide child abuse prevention philanthropy, and we also do work in policy and systems change. One of the things I always say is CTF's goal is to make Missouri the safest state in the nation to raise children. CTF also does a considerable amount of work in the area of child sexual abuse, and probably for the last 15 years I've been immersed in the world of how do you prevent child sexual abuse and what sexual predation looks like and how we protect children from sexual abuse. And so a lot of my experience comes, unfortunately, from seeing how bad actors and predators go after our children. And, I think that
always being a part of these conversations and being a part of this hearing and hearing the people that came before me always sort of changes my perspective on how I see things. And so I always think about what I'm going to say, and then I hear everybody, and I'm like, oh, I want to say different things now because I've, of course, been so touched by the people that came before me and the stories they're shared. And my real belief is that it only takes one adult to save a children's life, and the people in this room are saving lives every day. And I'm so grateful for that. I think that my point, though, even after hearing all of this, is that one of the things we have to understand is that we must have very strong protections when we're talking about vulnerable populations. So vulnerable populations, whether that's older folks, whether that's 3-year-olds, whether that's 9-year-olds, whether that's abused children, you must have really strong requirements in place, because what happens far too often is that bad actors and predators know how to exploit the chinks in our systems. And so licensure exists in our state because we must protect foster care children. Foster care children are deeply vulnerable. These are all children, by the nature of them being removed from their homes, have been deeply hurt. And so when they come into the custody of the state, there is a high bar that has to be met to make sure that where we place these children is very safe. And that exists for their protection, and it is an overall statewide response that we must maintain. I think that perhaps there are ways that we would, and I would love to explore more, how is licensure preventing these homes from really serving children? Are there places where we could perhaps change licensure? But creating an alternative to licensure is not safe. The Children's Trust Fund, again, believes that we all have to do our part to keep children safe. And I'm going to just close by saying that probably the most important part of all of this is that children are our greatest gift in life. Whatever we accomplish in our life, the power that we have, the wealth that we obtain, it means nothing when it comes to the gift that we get from being parents and being aunts and uncles and grandparents. And I believe that that love that we have for our own children and for the children in our lives extends to our policy and our duty to state and the children who are in the custody of the state. And so I just do ask that we consider very carefully and continue to maintain licensure as the mechanism for ensuring the safety of our children in foster care. Thank you.
Thank you for your testimony. Any questions for the witness? Seeing none, thank you again. I think that was at the beginning of this. There was 2 testifying here to testify against. Is that? I think okay, great. Didn't want to miss anybody. I appreciate Senator Schnelting, your time. And is there anyone here to testify for informational purposes only? Seeing none, thank you, Senator Schnelting. Appreciate it.
Man,
You want to wrap up?
Yeah, just 15 seconds. First of all, the comments were made that, well, let me rephrase, Madam Chair. DSS still retains authority in the decision-making process as far as making rules and regulations. Lastly, the idea that, in public schools we have about 10% of students that are abused by teachers. They're all licensed. Our teachers in our schools are licensed. So it's a false security blanket when we consistently talk about licensure being the end-all, be-all. So thank you for your consideration.
Thank you so much. That concludes the hearing. And we'll adjourn. Thank you.